Okay, so again, good afternoon to everyone. So this is just a review, and I have indicated this guide for all of you. I think this is also somehow related to your assignment, to your assignment as well on the cardiovascular drugs affecting the cardiovascular system. So from the concepts and topics that were introduced and presented in the recorded video discussion on the cardiovascular system. So if we go back to the functions of the cardiovascular system, the cardiovascular or the circulatory system obviously are composed of organs that is significant when it comes to the circulation. And when we talk about the circulation, it may involve the blood vessels and may involve primarily the hollow muscular organ, which is the heart. And the heart has a major function when it comes to provision of oxygenated blood, processing of oxygenated blood with the associated function of the pulmonary system in the conversion of non-oxygenated to oxygenated blood, and will provide the systemic circulation from the cardiac output. And I mentioned that the normal cardiac output is 5 liters per minute or 5,000 ml per minute. And cardiac output is necessary for the functioning of the brain. Actually, with the 100% composition of the cardiac output, 20% goes to primarily to the brain. The other 20% is intended for the kidneys, and the other 60% will be circulated to other organs. So why we considered most the kidneys and primarily the brain. So as part of the central nervous system, the brain is in control of the various major organs of the body. And the kidney primarily is the major organ that is responsible for excretion. So this is somehow a very important aspect of the allocation of the cardiac output of the heart. Simply, the kidneys are also the ones responsible for the electrolyte and fluid balance, which is very necessary for the functions of our cells. And the kidneys also have the function when it comes to the regulation of the blood pressure. So that's why the kidney and the heart is also connected. And when it comes to the brain is also in control of the function of the cardiopulmonary system. So when we talk about the heart as a hollow muscular organ, most of the major, or rather, the major composition of the heart is obviously muscle. So that's why, obviously, it can able to contract and to eject blood to its indicated organ or blood vessels, and the blood vessels itself also has the muscle, uh, what you call this, muscle structure that is also capable of dilating and pushing blood that will circulate it to the various parts of the body. So most of the problems that Filipinos encounter about cardiovascular problems are usually hypertension. And usually when it comes to the hypertension, it usually affects problem with the arterial blood vessels. So once it will affect there is an increased intravascular pressure affecting the arteries, it may compromise the supply of blood to the various major organs of the body. So that's why when it comes to the problem with the cardiac output, it may cause a major effect specifically to the brain. And as what I've told you, 20% goes to the brain. And that's why every time that there's a problem with hypertension, this may take risk to the problem with the cerebral function. So on this situations that the heart has a major responsibility when it comes to the circulation of blood and supply of the oxygen and removal of the waste products from the cells, then we must know some of the drugs affecting the cardiovascular system. Let us start with, as a review, the first part that I have discussed during that time is all about inotropic drugs. Actually, there are there are terms that could be associated with cardiovascular system. So we have inotropic, we have uh, inotropic, dromotropic, okay, and chronotropic. Okay, so if we say inotropic, this pertains to the muscle contractility. If we are talking about dromotropic, this entails to the electrical charges or response of the myocardial cells. And if we say chronotropic, this pertains to heart rate. So again, if we are talking about inotropic, this pertains to muscle contraction. If we are talking about dromotropic, this pertains to the electrical impulse transmission. So we have the conduction system that we are familiar with. So that pertains to the electrical impulse transmission. And the next is we have the chronotropic, which is related to the heart rate. Now, there are some drugs that are presented in various drug handbooks that goes positive inotropic drug, negative inotropic drug. The positive inotropic drug, so since we are aware that the inotropic is related to muscle contractility, and if it will be positive, the positive itself signifies stimulation, signifies increase. So its purpose. So that's why if you will encounter positive inotropic drugs, drugs that may increase muscle contractility. On the other hand, if you will encounter negative inotropic drugs, drugs that may decrease muscle contractility. Okay? So that's clear. So the inotropic is related to muscle contractility. How about dromotropic? If it is positive dromotropic, these are the drugs or drugs that may increase electrical impulse or conduction. Then if we have negative dromotropic drug, these are drugs that may decrease, okay, decrease electrical impulse or conduction uh, from the heart. If we say chronotropic, positive chronotropic, chrono, tropic drugs. Chronotropic is referred to the heart rate. So that's why if you will encounter positive chronotropic drug, this will pertain to increased drugs that may increase heart rate, and negative chronotropic drug are drugs that may decrease heart rate. So those are the terms that I presented to you as a background. However, we will focus on the first classification of drug as inotropic. Okay. Now, the first drug that I will have a review is all about cardiac glycoside. Okay. The cardiac glycoside will have rather three mechanism of action. Number one is activation of adenosine triphosphate. So ATP. Okay, ATP. So class, what is the purpose of the adenosine triphosphate in the blood vessels or in the heart per se? The purpose of activating adenosine triphosphate is to prevent vasoconstriction. E di ba usually the problem with hypertension usually coming from the resistance of the arterial blood vessels. So again, the purpose of the cardiac glycoside is to prevent vasoconstriction. So it gives us the idea that the number one purpose of activation of ATP is for vasodilation. Next, number two, promote movement of calcium. Okay, so what's the purpose? What's the purpose of the calcium? The purpose of the calcium is basically to help the blood vessels to dilate. Okay, which is very important for the ejection of blood. So the purpose of adenosine triphosphate is for vasodilation or prevent vasoconstriction. Number 2, the movement of the calcium is essential for dilation of the blood vessels, which is important to eject the blood. And number 3 is it acts on the central nervous system to enhance vagal tone. Okay, what is vagal tone? Once vagal tone is stimulated, it will decrease the forceful contraction of the heart. Kasi usually, when the heart is having forceful contraction, nag-i-increase ba ang oxygen demand or nagdi-decrease ang oxygen demand? If the heart has forceful contraction, do the heart increase oxygen demand or decrease oxygen demand?
Increase oxygen.
Increase po.
Very good. So,
Increase.
if it will increase the oxygen demand, then there must be a drug, or one of the properties of cardiac glycoside is it will stimulate the vagal tone. The vagal tone is the one that will stabilize or slows the contractility of the heart. That's why I even told you before, di ba, that most of the individuals who have history of heart attack, who have history of chest pain, as much as possible, they must prevent yung straining during defecation, lalo na if they are encountering constipation. Kasi usually if you are constipated while straining, it stimulates the vagal tone. Pag it will stimulates the vagal tone, your heart will slow and slow and slow. It's slow and decrease its heart rate and contraction, which eventually risks the client for cardiac arrest. However, the purpose of acting the vagal tone in the drug is to stabilize the contraction and prevent the forceful workload of the heart. So again, action of the ATP is to prevent vasoconstriction. The purpose of the calcium is to dilate the blood vessel, and the purpose of the vagal tone is to decrease the workload of the heart. There's only one drug, okay? Only one drug that are identified in cardiac glycoside, and that is digoxin, the only drug identified in cardiac glycoside. However, one of the nurse's responsibility is to consider the importance that if digoxin drug, kasi usually, di ba, we may know the therapeutic level and the toxicity level. And we have serum examinations or diagnostic examinations to test if the digoxin is reaching already toxic level, and that has a serum or blood examination. However, when it comes to digoxin, what could be if ever the client is taking digoxin and the client is not yet subject for serum diagnostic examination, what could be the reference of the nurse that the client is already has a starting condition of what we call digitalis toxicity? Sir, what's the difference between digitalis and digoxin? Actually, it is called as digitalis because the drug itself, okay, the drug itself comes from digitalis plant. So that's why digoxin, its source, and it is processed through the digitalis plant. So that's why if you will encounter digitalis, so that's pertain to digoxin or the cardiac glycoside. So this is primarily the sign of digitalis toxicity if the client will verbalize to nurses that she's already seeing yellowish spots. Visual. We are talking about the visual. She or he is seeing in the environment yellowish spots. And these toxic or adverse reactions are actually higher level of adverse reactions are signs that it really affects already the nerves, specifically the optic nerve. So that's why very peculiar that if the client will verbalize that she is seeing yellowish spots and the client is taking digoxin, that is pertaining to the starting or the pathognomonic sign that the client is having a starting toxicity of the digoxin. Now, we have discussed about also if the client is already have signs of toxicity, then what will be the antidote to counteract the toxic effect? Because we all know for a fact that when it comes to toxicity, it has been described that it's already life-threatening and dangerous on the part of the client. Now, as nurses, you need to prepare at all times antidotes in case that toxicity is confirmed and validated by serum examinations. So the antidote that is identified with digoxin toxicity or digitalis toxicity is digoxin immune fab, which was also mentioned if you have encountered the discussion pertaining to the antidotes and the therapeutic levels. Now, so when it comes to the digoxin immune fab, this will counteract the digitalis toxicity. So any question with the cardiac glycoside? So these are usually indicated for these drugs are usually indicated for the enlargement of the heart, hypertension. Moreover, these are on the heart failure. Sometimes if you will encounter a case of congestive heart failure, it means that from the term itself, congest, the heart is congested. Congested, ibig sabihin there's an existing pressure created on the walls of the heart, on the blood vessels and the various compartments of the heart. So eventually, what's the failure? Why it's failure? Because if there's congestion of the heart, it means that there's a failure to have cardiac output. So usually this drug are being administered to patient to treat heart failure. So Dean, same lang po ba yung Digibind said? Yes, yes, yes. Actually, thank you for that clarification. The digoxin immune fab is the same as Digibind. Okay, thank you for that clarification. Digoxin immune fab and Digibind are also considered as the antidote, and they are the same as antidote. Thank you so much. Next, let us now consider the number 2, the phosphodiesterase inhibitor. So, question, sir, we have encountered inhibitor. So why do we need to block the phosphodiesterase? So because usually phosphodiesterase is the one that causes the decreased muscle contraction. Phosphodiesterase, once stimulate, it may cause the blood vessel resistance or constriction. So there's a need, or most of the situation there's a need to inhibit this because it may affect contraction of the heart. So that's why it's under inotropic drugs. So since the purpose of the inotropic is to increase the muscle contractilities, which is very obvious that the purpose of the phosphodiesterase to inhibit the phosphodiesterase to purposely increase the heart contraction and at the same time to decrease the systemic vascular resistance. So what do you mean by decrease vascular resistance? So if we say resistance, usually if the blood vessels are not contracting and leads to constriction, so it may affect the blood flow. Sir, how about the venous return? The venous return that we're talking about is if the heart is, for example, not contracting, because contraction is very important for the heart to eject the blood. Am I right, students? Do
Yes
contraction is
po.
very important? Very good. Because once the heart is contracting, it increases the intracardiac pressure to eject the blood. If the heart is congested, meaning there is a concern with the stimulation of the phosphodiesterase, so it decreases myocardial contractility. Is there any chance that the volume of the blood stays in the various compartment of the heart? Will that be possible if it will not contract forcefully? Will that be possible? It just stays on
Yes
the... So
po.
if it will just stay in the heart, is it possible that it will continuously increase the volume of the heart or volume of blood in within the heart. Is it possible? Is it possible, students?
Yes po.
Okay, so if it will cause continuous increase in the volume of the heart, is it possible that the muscles of the heart will be overstretched and it will increase the size of the heart? Will that be
Yes.
possible?
Yes po.
If there will be enlargement of the heart, which is cardiomegaly, do you think the blood coming from the venous or coming from the vein can still enter the heart? Yes or no? If the heart is already congested and full with blood volume, do you think the blood from the vein that is supposedly going to the heart will be blocked or will not enter the heart? Yes or no?
Yes po.
Yes. Will it be possible that the blood in the vein may possibly have a reflux or backflow?
Yes po.
Yes po.
Yeah, so if that will cause the backflow, the blood vessel naman, the peripheral blood vessels naman will suffer and compromise the pressure. So that's why the phosphodiesterase inhibitor, its purpose, okay, its purpose is to increase the myocardial contractility, and the other one is to decrease the resistance of the blood vessels and prevent venous return. Because pag nag-venous return yan at bumalik yan into the blood vessels, what do you think kung si heart ay may enlargement na, tapos those blood that is supposedly going to the heart experiences backflow to the blood vessels, will it possible ba na pagka increase ang pressure sa blood vessel, lilipat siya into interstitial space? May possibility ba kung ganon?
Yes
Yes.
po.
So kung lilipat siya sa spaces, is it possible sa tissues naman siya mag-transfer? Sa mga tissues outside the blood vessel? Yes or no?
Yes po.
Yes. So that's why, class, most of the concern that you may observe is, di ba, by gravity, the appearance of the foot may cause the what we call pitting edema. So that's why, class, if a person is identified with enlargement of the heart, that's a possible congestive heart failure. And one thing that you need to identify, if the client has already pitting edema, specifically on the foot part, most that are affected are the right side. Kasi supposedly from the vein, pasok sa heart, sa right side, but since there is already a pressure on the right side, it goes back to the blood vessels and appears eventually as a symptom with pitting edema. Usually yan ang mga problem sa right-sided heart failure. Most nag-a-appear yan as pitting edema. And other than that, there could be a possibility that the kidney may not be capable of excreting the excess fluid. So that's why later on we'll discuss for congestive heart failure why there's a need for diuretics pa. But for the meantime, most of the drugs that are considered as phosphodiesterase inhibitor are drugs ending in renone. So milrinone, lahat ng mga renone ending in renone. Milrinone, parinone, milrinone. So those renones are phosphodiesterase inhibitor, and these are inotropic drugs. Now, very important for the nurse to remember is these are drugs that are given for short term. It is given for heart failure. So ano again yung consideration natin why there is heart failure? Because there's already increased pressure created in the heart. So that's congestion. And the failure that we are talking about is the heart is having failure to give the normal cardiac output. So short term siya. Okay? Hindi siya this drug may not be on a maintenance level. Okay? So because once the client will be treated with the heart failure, then it may not serve eventually as a maintenance during only the period that the client is being treated with heart failure. If the client has heart transplant, then that's the time that this phosphodiesterase inhibitor or renones are given as a long-term therapy. That's for heart transplant. Okay? So any question with the first inotropic drugs? Students, any questions? So 5, 4, 3, 2, 1, hearing none. So I will proceed to the next slide. The next slide are those drugs as anti-hypertensive drugs. Later on, the next slide will summarize on what are the classification of hypertension that had been identified in the Joint National Commission or JNC7. Most of you, definitely, you will agree with me. If you will be asked, what is the normal blood pressure? I know all of you will answer me 120/80. Am I right? Most of you will answer 120/80. But based from the JNC7 on the classification of hypertension, 120/80 is already pre-hypertensive level. So this is a pre-hypertension level na. The normal is below 120. So what do we mean by below 120? It means 179 and below. 119 and below. For the diastolic, it's 79 and below. Those are the normal. But once it reach already 120/80, oops, it's pre-hypertension. So it means that anytime it may lead to the level of hypertension. So that's why from the perspective that I have oriented you about the concern with the discussion of preeclampsia and the eclampsia, 'di ba? The difference between the gestational hypertension and the preeclampsia. So pag gestational hypertension, may evidence there are evidence of hypertension but no proteinuria. Pagka preeclampsia, merong hypertension and at the same time meron na siyang proteinuria. So it's very important to identify if the client is already having gestational hypertension. So if my apology, my connection had been interrupted. So I'll just share again the screen. Okay, so let's go back. So when it comes to what I have mentioned, hypertension, later on I'll be showing to you the slide, and I have already presented this in my recorded video. So let's have centrally acting. What's the difference between centrally acting adrenergic inhibitors and peripherally acting adrenergic inhibitors? Okay, now kasi when we talk about so it used the inhibitor. For a while, I'm encountering a problem with my connectivity. Okay, let's go back again. I'm sorry for that interruption. So when we talk about hypertension, we're talking about again a concern with the JNC7, which I will show on my next slide. Now, there are two drugs that are other than with the next or succeeding classification. We have centrally acting adrenergic inhibitors and the peripherally acting adrenergic inhibitors. So let's start first with centrally acting. Class, remember if you will encounter in the board exam, if considering peripheral vascular resistance, it is always associated with hypertension. Okay? So that's why class hypertension may not just only be associated with the heart. If there is a peripheral vascular resistance affecting the liver, the blood vessels of the liver, there's a resistance. That's what you call portal hypertension. So if it considers the vascular resistance in the pulmonary, that is pulmonary hypertension. If there is a vascular resistance affecting the heart, then that is obviously cardiac hypertension. So now, why do we give centrally acting adrenergic inhibitors? Class, remember ha, this is a drug that are usually administered if there is a sudden increase of blood pressure. This is very common, okay? This is very common as an emergency drug. So one of which is actually the purpose of having stimulation of alpha receptors in the central nervous system. So again, receptors. Okay. The receptors will, these alpha receptors are stimulated in the CNS so that to prevent vasoconstriction. So we are talking again of resistance. And this will reduce peripheral resistance. So the common denominator of discussing hypertension will always boil down with the problem of vascular resistance. So that's why in hypertension, you will always encounter reduced vascular resistance, either peripheral resistance, systemic vascular resistance. So those are the points that you need to remember. So for centrally acting adrenergic drug, these are the drugs that are considered clonidine, and we have methyl-dopa. Okay? Clonidine could be administered sublingual. Okay? This is an emergent centrally acting adrenergic drug. So if it is given sublingually, it will manage directly. Kaya from the term centrally acting, it will direct the management of blood pressure so that it may stabilize the problem with it. So, but the nurse has to take note, more importantly, the following. Once the client has taken clonidine or methyl-dopa, it may darken the urine as expected in some of the drugs. Kasi most of the drugs may significantly have change in the urine color. However, darkening the urine is very common with centrally acting adrenergic drugs or inhibitors. Now, usually, clonidine or methyl-dopa are taken at bedtime. Why at bedtime? This is to prevent orthostatic hypertension. Do anyone knows what orthostatic hypotension is? Do anyone knows what orthostatic hypotension? Anyone? Anyone?
Change of position din.
So that's wherein there's a low blood pressure. There's a low blood pressure that will subject or that will low blood pressure when the client change its position from either sitting or standing. So that's why very important to consider that if this is taken at the bedtime, because at the time that the client takes this drug and goes to sleep already, so the client is already at rest and may not have change in the position such as sitting and standing. Kaya that's why once the client takes these centrally acting adrenergic inhibitors, you must instruct the client to stay on bed. Okay, because of the chances of if the client immediately stands or immediately sits, it will cause immediate lowering of the blood pressure. So that is orthostatic hypotension. So that's one that you need to consider as a nurse. Next po, peripherally acting adrenergic inhibitors. Usually, as what I've told you, when there is hypertension, one of the major organ connected to the heart to regulate the blood pressure is what organ? What organ? Huh? What organ? What organ is connected to the heart that regulates the blood pressure?
Liver po din.
Any other guess? Any other guess?
Kidney po.
Yeah, it's kidney. So the kidney is also responsible for the regulation of the blood pressure, and at the same time, when the kidneys are helping the heart by releasing the what we call norepinephrine or epinephrine by the adrenal gland. So the norepinephrine, the adrenaline. Okay. So the problem is usually usually because of the sympathetic response, of too much sympathetic response of the release of the adrenaline, it may cause the possibility that it may cause the what we call vasoconstriction. So that's why usually, eventually, when you've heard about hypertension, if there's hypertension, the the kidneys will release adrenaline. Upon release of adrenaline, it will stimulate the release of renin. So automatic yon, yung renin, i-release yon ng kidney. So but the problem with the release of renin is that of it will risk the problem with the angiotensin 1 that will cause the vasoconstriction. So that's now the problem. The renin can be reduced, but the angiotensin 1 is the one that may cause the vasoconstriction. So that's why this drug may reduce eventually to a level na okay, enough lang yung adrenaline or norepinephrine that will be released and help the heart to regulate blood pressure, and obviously to decrease the sympathetic vasoconstriction. So obviously, if you will notice from the drugs, from the start of the discussion of the drugs, it's always a concern with vascular resistance and vasoconstriction, because vasoconstriction itself is a form of blood vessel resistance. So sabi natin, as what I've told you, the kidney regulates blood pressure by releasing norepinephrine or adrenaline, but the renin goes in, and after what angiotensin releases, then the angiotensin 1 is the one that causes vasoconstriction. So later on, we'll discuss that further, because there are other drugs that may facilitate the problem with angiotensin 1. So in this consideration, the drugs that are referring to peripherally acting adrenergic inhibitors are zosine. Drugs that are ending in zosine. So prazosin is a most common drug. So zosine. So the important reminder for nurses, for those who are giving these drugs ending in zosine, as much as possible, if you are giving clonidine and at the same time you are giving zosine, you must not give the drug on the same time frame, because there could be what we call drug interaction. So the drug interaction that may happen is it may decrease the effect of clonidine. So that's the point. If you are giving clonidine, if the patient rather has clonidine or methyldopa and at the same time has zosine at the same time, make sure that this drug must be given on a separate time interval, because the clonidine will be affected if given at the same time when it comes to its effect. Okay, so any question from the centrally acting adrenergic inhibitors and peripherally acting adrenergic inhibitors? So if none, may I continue to the next slide? To continue with the next slide, this is what I'm talking about when it comes to the drug most are given as an emergency drug, yung centrally acting adrenergic inhibitors, clonidine or the methyldopa, because we must be aware of the hypertension classification guidelines. If you will notice, the normal, that's why from the sign, it must be lower than 120, and lower diastolic BP of 80 is considered as normal. While the prehypertension is already 120 to 139, and the diastolic blood pressure is 80 to 89. Now, for the stage 1 is we have 140 to 159, and the diastolic blood pressure is 90 to 99. Stage 2 is usually if it's above already 160 and above 100. Kaya that's why most of the drugs, remember this class clonidine or methyldopa may be given on a situation if the client's blood pressure is above 160 and above 100. So that's why if it goes that, simply the client, if non-hypertensive, then may rest. But eventually, if the client is already non-hypertensive, then the client must take the drug because it may aggravate sooner na chances na ito po ay mag-lead into complications. So I will accommodate questions. Din, okay lang po ba mag-administer ng clonidine at saka zosine since pareho po silang anti-hypertensive? Yes, pwede po siyang magbigay both. But as what I have told you, it must have a different time interval kasi nga it may counteract yung effect ng clonidine when given with prazosin. Kasi if you will notice with someone or individuals who are having anti-hypertensive drugs, multiple maraming anti-hypertensive drugs the person is taking because it has different actions. Pwedeng nagtitake siya ng centrally acting drug and at the same time nagtitake siya ng peripherally acting drug. So on that note, may mga situations na usually ang centrally acting adrenergic drug are usually given pagka ito po ay nasa stage 2 hypertension na ng mga 160 over 100. Usually pag mga usually pag mga pag walang clonidine, methyldopa is the one that are being given. So yun po. So another question is am I clear na po? Clear na po ba ako ulit? Okay. So another question, ano naman po yung classification para malaman na hypotensive or low blood na? Actually, there's no classification. There's no classification that the client is already reaching hypotension. However, pag sinabi natin na ang normal, sabi nga natin, 'di ba, the normal is 1 kasi class ito, remember this when you search ito sa mga search engines, may mga may mga appropriate or normal blood pressure for children, for adult, for aging, or for the elders. Kasi it varies with the physiologic response of the body. So, it may also vary by age. Okay? The blood pressure may vary also by weight. But moreover, the reference that we may have is the normal blood pressure by age. So that's why we must be aware also that, for example, yung mini-mention natin na ito na below 120 and below 80 is for the adult ito. Pero once pag ang person na po ay nag 90 over 60, ay for adult this is already hypotensive. Pero for the age of pediatric individuals, there are some situations that 90 over 60 at a certain age is normal. So that's why be very cautious when it comes to the interpretation. The one that I'm presenting to you now is the JNC7 for adult. So it could vary pa the normal classification for the pediatrics. So okay. So since marami pong zosine drugs, how should we choose which is the right zosine drug or specific patient na may hypertension? Okay, class, the zosines, since identified siya as peripherally acting, anything that is ending in zosine, any generic that ends in zosine is peripherally acting kasi we will look into the generic rather than the brand name. Okay? So the two identified for centrally acting are clonidine and the other one is methyldopa. But for the peripherally acting drugs, zosines, generic name. Okay? By generic name. So maraming lalabas yan. Prazosin, melrinosin, so zosine, zosine. So any na lumabas in the market but the generic ends in zosine, these are peripherally acting adrenergic inhibitors. So hoping everyone is aware of this already so that it may apply to your skills and future endeavors when you encounter individuals. So kaya pag naka-encounter ka na 120/80, so somehow you are on pre-hypertension. Kaya pag tinanong po kayo, normal is below 120 systolic blood pressure and below 80 diastolic blood pressure according to JNC 7. So usually pag mga stage 2, 160/100, these are the situations that the client is already receiving mga centrally acting adrenergic inhibitors for emergency situation and given sublingually. Okay? Next po, let us now proceed. I'm sorry. Let us now proceed with this one. So I think I have missed one okay. So I think I have missed the drug example in this. So we will just correct this one. Okay. Usually the angiotensin converting enzyme inhibitors, ACE inhibitor. So class, please correct na lang po tong other table. I will send the corrected one. The angiotensin converting enzyme or ACE inhibitors are those drugs ending in pril. Okay, so please correct po. My apology for this slide. I have to correct this. Yung pril po dito, must be supposedly in this table sa taas. Okay. So please take note of that. So the angiotensin converting enzyme inhibitors, so the purpose of this is to reduce the blood pressure of renin, angiotensin, aldosterone system. Okay. Ito yung na-mention. This is the one that I emphasized a while ago. Na pag ACE inhibitors, those drugs ending in pril. Okay, this is in pril. Please correct the pril that dapat yan nasa ACE inhibitor. Pril, ACE inhibitor are those drugs ending in pril. As what I've told you, during hypertension, the problem is that of renin, upon release of epinephrine, renin goes out. Okay, the renin goes out and the angiotensin 1 is stimulated. So yun yung nagko-cause ng vasoconstriction. So the purpose of the ACE inhibitor, from the term itself, angiotensin converting enzyme inhibitor, the one that is being interrupted, the one that is being reduced is the renin. Okay, the renin angiotensin. So because we all know that the effect of the angiotensin is vasoconstriction. So yun po. Class, ganito po yan ha. Usually pag if the person has a good urine output, because it has an implication, class ha, pag ang person is hypertensive, make sure to monitor also the urine output. Kasi if there are situations that the person is hypertensive pero the person is not having a urine output or not having urine output, that's an indication that the kidney is not regulating the blood pressure. That's why if you will be assigned in the ICU attending to clients, so situations like na you need to monitor intake and output every hour. So the problem is the patient is hypertensive tapos the kidney has no urine output. Okay, so there's something wrong with that. It means that the kidney is not regulating the blood pressure. So that's the time that you must be alert that the kidney's capacity is not sufficient. So that's why this drug is simply indicated for that situation na nagsisimula pa lang na there's a problem with urine output. So usually the purpose of this ACE inhibitor is ma-prevent din siya na yung angiotensin 1 ay ma-convert sa angiotensin 2 kasi angiotensin 1 nagko-cause na siya ng vasoconstriction eh. How much more if it will lead to angiotensin 2, the more blood vessels are constricted. So that's a worse condition. That's why sometimes pagka, 'di ba, if you will notice, pagka ang problema ay nagkaka-hypertension na tapos affected na yung kidney, doon na that starts already that the kidney are affected at chances na need nang i-monitor ang kidney because there's a chance na pwedeng mag-lead into kidney failure. So, class ha, all you have for those individuals that you have known who are hypertensive, always take into consideration to check the kidney function. Because if the person is having hypertension tapos the creatinine, which is the reflection of the kidney function, is increased, it means okay, there's something wrong when it comes to the regulation of the blood pressure. So that's why yung that's related pa rin dito sa renin angiotensin. Kung hindi pa masyado, if it is not yet evident na affected si kidney, okay, we can start with ACE inhibitor or mga pril. Okay, what will be the important consideration when giving pril? Ano yung mga pril na to? Enalapril, captopril, enilapril. So anything, pera lang ang April. Okay, so those drugs, the pril, okay, the pril ending in pril are ACE inhibitors. So usually these captopril are given 1 hour before meal on an empty stomach. You must remember that, ha. Any pril, but most captopril are given on an empty stomach for purposes of effective absorption. Now, since ito po is we need to monitor na the kidney function, hoping for a client who's taking captopril, you need to monitor for presence of proteinuria. Okay? Why? Kasi usually the routine is when the person is taking captopril, you need to monitor every 2 to 4 weeks for first 3 months kasi nga the proteinuria itself may affect the kidney function. So dapat hindi mag-appear ang protein into the urine unless klasa, if the patient is taking ACE inhibitor or prils tapos it appeared already in the urinalysis that there's proteinuria, lilipat na tayo dun sa number 6. We'll transfer to the number 6 because eventually the number 5, the prils are not anymore effective to the situation of the client. If the client has already proteinuria, ibig sabihin the kidney is worsening its condition in regulating the blood pressure. So ang kidney is continuously releasing epinephrine. Yun nga lang, the problem is the continuous response of the kidneys will cause the problem with the renin angiotensin. And si angiotensin posible na na-convert into angiotensin 2. Plus, what could be the worst condition of this? Kasi pag nag-cause na si angiotensin 1 to the angiotensin 2 and kidney will not anymore release epinephrine, the heart will not will cause its increased hypertension and eventually mag-stop yan. So posible bang mag-cardiac arrest yung pasyente? The answer is yes. So that's why we need to have na kung halimbawa ang patient mo is having anuria for 24 hours or for few hours, no urine output. So that's an indicative condition that the kidney is not responding. So kailangan na natin ng drug to help the kidneys in regulating the blood pressure. So that's why we need to have na angiotensin 2 receptor blocking agents or angiotensin 2 blockers. So this is to block the binding. Kasi kanina, we block conversion puntang angiotensin 1, renin angiotensin 1. But sa angiotensin 2, the presence of proteinuria is already very evident that there's angiotensin 1 already. So that's why we need to take into consideration na wag na, it may inhibit to convert it in angiotensin 2. So, class, just take note of this. I'll just correct the sample, the drug examples. The drug example of angiotensin 2 are those drugs ending in sartan. Again, angiotensin 2 receptor blocking agents are those drugs ending in sartan. So, angiotensin ACE inhibitor are ending in pril. Angiotensin 2 receptor blocking agents are drugs ending in sartan. Valsartan, irbesartan. So those, losartan, very good, losartan. These are very common na binibigay from the health center, right, di ba? So losartan. So ibig sabihin pag ang patient is already taking losartan, ibig sabihin it needs to regulate na the kidney because the kidney is weak na to regulate the blood pressure. So yun. So those are mga sartans, mga angiotensin 2 receptor blocking agents. So please correct. the drug examples, but the mechanism of action of the two are correct just on the drug example. So ACE inhibitors are pril, angiotensin 2 receptor are sartans. Next, so we have the calcium channel blockers. So obviously, the purpose of the drug is to block the calcium. So as what I've told you, if there are resistance in the blood vessels, the calcium is released to keep the blood vessel dilate and eject blood. But the problem is too much stimulation, kung continuously there is vascular resistance, the problem is calcium will continue to release. So if the calcium will continue to release, ang problem mag-lead into decalcification. Kaya if you will encounter the term decalcify, it means hardening. Okay, hardening. For medical term, it is sclerosis. Okay, sclerosis. Kaya that's why if you will encounter arteriosclerosis. So what does it mean? The arterio is a blood vessel. Sclerosis is hardening. So if you will encounter arteriosclerosis, hardening of the artery. So what is the cause of the hardening of the artery? It's because of the too much calcium. Okay, the too much calcium that compensates because of the vascular resistance. So meron din palang disadvantage of too much because it may harden the blood vessel. So what could be the drugs? All drugs ending in dipine, nifedipine, amlodipine, felodipine, so lahat ng dipine. Usually, nifedipine is the one given sublingually. Okay? Sometimes there are situations like na ano siya yung mismong kasi capsulated yan. There are some instances na piniprick yan, yung liquid form pinepress and para mas madaling ma-absorb under the tongue. So the nifedipine is the one being given sublingually. And the other drugs that are not ending in dipines are verapamil at diltiazem. These are the two drugs. Remember these two drugs na calcium channel blockers other than the what we call dipines. So what is important again, if the systolic blood pressure, ayan na, if the systolic blood pressure is less than 90 and the heart rate is less than 60, withhold the drug. Withhold the drug. So remember below 90 systolic and below 60 heart rate, withhold the drug. It is on your premise and it is on your independent function to basically withhold the drug because of the risk of chances that it may lower down blood pressure and cardiac rate. Okay, next, we have diuretics. Diuretics usually, ang problem pag ito connected ito sa hypertension Kasi sabi natin, ayan na. Sabi natin, the kidney is the one that helps the heart to regulate blood pressure. We are aware that the adrenaline is released, renin is released, angiotensin 1 vasoconstriction, angiotensin 2 more blood vessels are constricted. If the blood vessels are constricted, do you think the kidney will still be effective in functioning? The answer is no. Usually, yung electrolyte regulation is and fluid balance are function of the kidney. The problem is this: instead of releasing the excess sodium, what happens is that because of the situation of the angiotensin 1 to angiotensin 2, the sodium is reabsorbed. Di ba class ang sodium attracts water? Do you know that sodium and chloride attracts water? Students?
Yes po.
Yeah. So pag na-reabsorb yan ng kidney, lalong magkukos ng attraction of water. So will it cause ba further congestion? Yan? Pwede ba mag-cause ng further congestion sa kidney? And
Yes, sir.
Yes po.
Yes, that's it. So that's why the concern is it must induce the what we call urine output. So that's why the purpose of the diuretics is to remove excess fluid, to increase urine output, to decrease edema, to circulate the blood volume and to increase cardiac output. So kasi the kidney must help the heart. Kaso yun nga, if nag-angiotensin 2, re-reabsorb niya si sodium chloride, it may cause further fluid volume excess. So magkukos lalo ng congestion, si heart lalo magko-congest because the kidney is not responding. So diuretics is very much important. However, as what I've told you, na it's very much important to check on the weight. Okay? Kasi class, remember, na pagka ang patient ninyo ay nagtitake ng diuretics tapos in 24 hours, nag-i-increase yung weight, is there something wrong with that? Within 24 hours, nag-increase yung weight niya?
Retention of fluid.
Very good. So there is a retention of fluid, something happening. Kasi kahit naman tayo, if we'll eat, or if we have full meal in a day, it doesn't increase automatically our weight the other day because it's a process. Kasi our body is processing metabolism. Pero somehow, if within 24 hours, there's an increase in, there's weight gain in 24 hours, there's something wrong that the diuretic is not taking its effect. So dapat consider that. Another is you need to take into consideration of extensive peripheral edema. Peripheral edema, I'm talking about most yung sinimension ko na pedal, pedal edema. If it increases the extent of the edema and the client is having diuretics, so there's really something na wrong with the diuretics. So it will look for other diuretics as well. So the diuretics that we're talking about are those drugs ending in "mide". So very common ay furosemide. Very common yan. Tapos sa mga thiazides, ito yung mga drugs ending in thiazides, chlorothiazides, thiazides, yan. So another is you need to monitor for hypokalemia. What is hypokalemia? This is decrease in the level of what electrolyte? Potassium. Very good. Okay. So class, because since it will induce urination, the one that the nurse must monitor is the chances of too much potassium will be released. Sodium and chloride, no problem tayo with that. Kasi that's the one that possibly cause reabsorption eh. Pero pagka nanggaling na from intracellular compartment which is potassium, class, potassium is really very important for cardiac for cardiac impulse transmission. Kaya pagka nag-hypokalemia na yan, that's the time na pwedeng maka-affect yan directly to the heart. So that's why you need to monitor for the signs of decreased potassium level. Okay, now let us now proceed with anti-anginal drug. So I think I have mentioned before what's angina. So do you know what angina is?
Chest pain.
Chest pain, very good. So usually, chest pain is caused by insufficient oxygen supply to the myocardial cells. And usually, affected dito ay blood vessels. If you will notice, in the previous drugs that we have mentioned, most of the concerns with hypertension are vascular resistance, vasoconstriction. So that's why the most common problem that delays the blood supply and the oxygen supply to myocardial cells are vasoconstriction. So that's why we need a vasodilator. So usually nitrates are also called as vasodilators. So obviously, the action is it produces vasodilation, decrease preload and afterload. Okay, I know that the preload and afterload have been discussed in your anatomy and physiology. Yung preload is the time that the heart is receiving blood. So that is during diastole. The afterload is the time that the heart is contracting and ejecting blood. So, kailangan kasing ma-decrease yung preload and afterload kasi parehong pressure siya. Kaya for example, mataas yung systole. If mataas yung systole, ibig sabihin the heart is keep on contracting. Do you think it will it will enter pa yung blood coming from the veins to the right side of the heart? It may inhibit kasi because mataas yung systolic pressure. The more na tumataas yung systolic pressure, the greater chances that the blood can enter the heart areas or compartments. So in this situation, because of the problem with the heart and problem with the oxygen consumption, so nire-reduce niya yung myocardial workload. So most of the common examples na binibigay po natin na drugs are drugs ending in nitrates. Ito po yung mga dinitrate, mononitrate, trinitrates. So may nitrates sa huli yan. But the most common po na binibigay for emergency chest pain ay ang isosorbide dinitrate, yung Isordil. It is given sublingually. Okay? Sublingually, so fast action siya. And usually, ang maximum dose nito, usually 5 milligrams per sublingual. Pero the maximum dose na pwedeng ibigay ay only 15 milligrams in 15 minutes. Kasi ang interval of giving the drug, for example, first 5 minutes, the purpose of the nurse is to relieve the chest pain. To relieve the chest pain. Pero pag hindi pa rin na-tolerate yung relief ng chest pain, another dose of Isordil or isosorbide dinitrate. Next, hindi pa rin na-relieve. So last dose na to, last chance na. So third dose of the third tablet, which is 5 milligrams, so 15 milligrams in 15 minutes. Class, pag hindi pa rin na-relieve yan, hindi pa rin na-relieve ng maximum dose of 15 milligrams ng 3 doses, alam nyo po ba na pag nag-exceed ng 15 minutes, it's already heart attack. Very crucial. Myocardial infarction na yon, MI na. Heart attack na yung susunod doon. Kaya kailangan na tayong mag-seek ng medical attention if hindi na-relieve sa 3 doses ng nitroglycerin or nitrates, yung Isordil. So, class, it is advisable to avoid alcoholic beverages kasi the alcohol itself may cause vasoconstriction. So it may counteract the effect of the nitrates. Okay? So remember those important points. Next, we have beta-adrenergic blockers. For beta-adrenergic blockers, so ito yung beta blockers. So na if you can still remember the receptor, beta receptor. Yung beta receptor ay si adrenaline ay na-release, ang nakaka-receive ng signal that will increase the contractility of the heart by a myocardial cell ay ang beta receptor. And the beta, that's why may adrenergic sympathetic response. So, ang concern nito kailangang i-block kasi forceful na yung workload ng heart, so slow na yung heart rate at to decrease the force of myocardial contraction. Usually, these are given sa mga clients na may mga hyperthyroidism. Very common to, yung mga propranolol, atenolol. Why? Kasi pag may hyperthyroidism, usually they experience palpitations. And palpitation is a forceful contraction of the heart. So kailangan ma-decrease yung force ng myocardial contraction, thus decrease heart rate. So olols are the ones being given. So what will be most important is to withhold the drug if the pulse rate is less than 50. Okay, withhold the drug, take 50. Tapos, observe the patient with diabetes on hypoglycemic shock. So, ano yung hypoglycemia? Hypo is decreased.
Low blood sugar.
Yes, very good. This is a common monitoring pag nagbibigay ng beta blockers. Kasi ang beta blockers na i-inhibit niya yung insulin production. Di ba ang insulin is very important to break down the glucose. So yan yung problema, lalo na for may mga diabetes. So pag nag-lead na yan sa hypoglycemic shock, yung shock itself, yung level of shock is ano na yan, parang extreme, too much decrease na. Hindi naman too much. Talagang very low sugar level na pwede nang ang problem ay hindi na nakaka-reach yung oxygen sa cells. So that's one that you need to take into consideration. Next, we now proceed to the last 3. Okay, for the last 3, we have the anti-lipamic drugs. From the term itself, lipamic, lipidemic, cholesterol. So yan, mga lipemia o hyperlipidemia. So lipids. So as a review of the anatomy and physiology, the cholesterols are insoluble. So it is processed and delivered via the plasma. And these are encapsulated by lipids or lipoprotein. So there are two lipoproteins that we may identify that encapsulates the cholesterol. We have the low density lipoprotein or LDL, or the HDL is the high density lipoprotein. So these are the somehow sabi natin when you encounter, oh, good cholesterol is high density lipoprotein and bad cholesterol is the low density lipoprotein. On the perspective, that's true because most of the low density lipoprotein are the ones that causes obstruction of blood vessel. So one of the three classifications of anti-lipemic drugs are the following. Bile acid sequestrants. Ang bile acid sequestrants, usually class, remember, another that regulates cholesterol is the liver. Class, remember na pag ang clients mo ay nagtitake ng anti-lipemic drugs, kanina ang monitor natin ay kidney function. Pag ang patient naman natin is taking anti-lipemic drugs, ang minomonitor naman ay liver function. So, in this situation, the purpose of bile acid sequestrants is to lower down the LDL, which is the bad cholesterol, at to facilitate the clearance of cholesterol by the synthesis of the bile. Okay, bile by the liver. That's why it's bile acid sequestrants, because it's regulated by the liver. So that's why most of the drug identified here is cholecystiramine. Okay, cystiramine, but it's different from different ito sa histamine hindi siya kasama doon cholecystiramine, so ramine, and cholestyramine are the two drugs identified with bile sequestrants. Usually po, these drugs are given 1 hour before meal at ang interval na po ay 4 to 6 hours after taking another drug. The purpose of that interval is to facilitate a good metabolic response to have cholesterol clearance by the liver. So yun. So next is we have the fibric acid derivatives. So ano naman ang natin sa fibric acid? Usually this is still regulated by the liver. So it decreases hepatic synthesis and usually breakdown ulit ng LDL. So what's the common with the two? The common with the two drugs are related to the low density lipoprotein. And most common example nito ay mga fibrate. Lahat ng may drugs na may fibrate sa huli, sa generic. Another drugs ay gemfibrozil at niacin. If you will go back to anatomy and physiology, ang niacin po, ang purpose ng niacin is it regulates the high density lipoprotein so that to synthesize the breakdown of the low density lipoprotein. So usually, ang mga fibric acid derivatives po ay binibigay. These drugs are given nighttime. Kasi remember class, cholesterol may be possibly synthesized effectively on daytime because we are engaged into physical activities. But at nighttime, kaya that's why there are some situation, di ba, may mga hypertension or mataas ang cholesterol, usually you must have the proper dietary management at night. Lalo na kung for example, too much ang kinakain. So nag-i-increase yung dapat na expected metabolic response. Kaso nga 'di ba at night time, after you eat, pag inantok, tulog. So once you are asleep already, your metabolism is low. And if the metabolism is slow, the cholesterol synthesis is also slow. So that's why usually nangyayari ang mga chest pain na yan pagka yan sa for example at night na biglang sudden ng attack because yung too much na pagkain ninyo causes the possibility kung high fat pa siya at high cholesterol, ineffective ang synthesis ng cholesterol. So that's why if you can't control it of eating too much at night and high cholesterol pa yon at high ang cholesterol level ninyo, the fibric acid derivatives are the choice that are given before sleep or evening meal. So next, last one for the anti-lipemic. Eto familiar to, kaso parang we have discussed this before na ang mga statins meron siyang toxicity. May mga toxicity ito. Usually sabi natin dito ang statin nephrotoxic, ang statins din ay hepatotoxic. So careful din. So on this regard, usually ang HMG-CoA reductase inhibitor, again, the liver is the one responsible for this and to prevent cholesterol synthesis. Ang HMG-CoA kasi is the one that regulates the cholesterol. Pero kasi ang problem nito is pag ang liver is not effective when it comes to synthesis, kailangan i-block yung HMG-CoA para ma-prevent yung cholesterol synthesis. The cholesterol synthesis is significant para hindi masyadong tumaas yung LDL. So that's why it reduced the LDL level. So if you will notice with the three anti-lipamic drugs, ang target niya talaga ay low density lipoprotein. At usually ang mga statins, fluvastatin, pravastatin, simvastatin, rosuvastatin, lahat ng mga statins usually are given at once a day yan pero at bedtime. Common. Kaya if you will notice at bedtime yung fibric acid derivatives at saka HM-CoA reductase inhibitors. So again, advise the client to restrict alcohol because again, the alcohol causes vasoconstriction. So this is the summary of what had been discussed in the three parts of the cardiovascular drugs. Any question? Any question, students? Any question, class? Ayan. So I receive a question from the chat box. Okay. Din, bakit po ulit bedtime? Okay. It's given usually at bedtime because the body's metabolic or physiologic metabolic response is low at nighttime rather than daytime. So ang cholesterol may not be synthesized effectively sa nighttime, kaya that's why these anti-lipamic drugs are given at bedtime. So okay, so we will now proceed to the discussion of the respiratory drugs, but I think you deserve a break before we proceed with the respiratory drugs. So I will accommodate one question. Okay, so before we proceed with the respiratory drugs, I'll just want to give you an overview of this. Class, respiratory drugs nowadays are very significant because of the COVID-19. So that's why those drugs that we will take up on this part is very significant because these are the usual drugs that are being prescribed for clients with COVID-19. So I may start with the first, then we will have a break. So for drugs and respiratory system, very obviously bronchodilators. So the bronchodilators are more on sympathetic or parasympathetic response. Bronchodilation. Sympathetic or parasympathetic? I'm not hearing answers. Students? Sympathetic or parasympathetic? Bronchodilator.
Sympathetic po.
Yeah, it's sympathetic. Okay. Now, actually class, all of us rather, all of us has the what we call CAMP, yung cyclic adenosine monophosphate. Kaya that's why every time that you will encounter pollutants, kasi di ba usually yan, you will cough, you will sneeze. That's an indication that the cyclic adenosine monophosphate is stimulated to keep your airway open. Kasi once there is an irritation of the bronchial muscle or the bronchial mucosa, the irritation itself may cause constriction. That's why it's different. It's different for a situation that when the client is asthmatic. Kasi naturally, hindi siya magre-respond for individuals who doesn't have asthma. Because those persons who may not have the asthma can tolerate exposure to these pollutants. But for those who may have asthma, this may trigger because the cyclic adenosine monophosphate is the one that is responsible for relaxation of the bronchial smooth muscle. Kaso for those who are asthmatic, ang cyclic adenosine monophosphate ay nabablock at nagkokos agad yan ng constriction or nagkokos na agad yan ng bronchial muscle constriction. Kaya mabilis ang difficulty of breathing for those who may have the asthma or what we call chronic obstructive pulmonary diseases. So ang purpose ng bronchodilators ay CAM. You have noticed also and have you observed na pagka mga elderly patients, these are the individuals na once exposed to any allergens or pollutants, they are the ones who may encounter difficulty of breathing kasi class elders may have decreased level of cyclic adenosine monophosphate compared to adult and compared to pediatric clients. So that's why in those situations, let us protect our elders when it comes to this pollution or anything that may cause a problem with difficulty breathing because expected the CAMP or cyclic adenosine monophosphate is expected to decrease for elders. Now, in this situation, what are those drugs? Okay. Yung mga drugs na ito ay those drugs ending in rol or ol. Rol or ol. Rol, renol, rin. Yung rin kasi, yung rin, ano rin yan eh, ephedrine, epinephrine. Oh sir, parang it sounds familiar. Yung epinephrine tsaka ephedrine. Kasi di ba yan yung sympathetic response? Yes, kaya nga siya adrenergic agonist eh. Ang epinephrine at ang ephedrine, it's not just only for the heart to help the heart to pump, but it also opens the airway passages. Kaya during cardiopulmonary resuscitation, yung epinephrine is given because it facilitates cardiac contraction and at the same time it open the airway. So other than that is those drugs ending in ol or renol or renol. Ito po ay mga drugs such as albuterol, salbutamol. Yan. Renol is different, ephedrine and epinephrine. How about for those sir na ano na mga somehow hindi na conventionally treated by the albuterol, Terenol and ephedrine and epinephrine. So pupunta na tayo sa long acting kasi hindi na nag-respond to conventional treatment. So ito na po yung may nadagdag na long acting bronchodilators na ipratropium. Usually these are the drugs that can be given via inhalation or nebulization or by metered dose inhaler. Yung metered dose inhaler, yung pag-pump, pag pinump mo, so direct to the airway yan. So lahat ng may mga ipratropium plus albuterol, Combivent, ang brand name yan, ipratropium plus bromide atrovent, these are the drugs na long-acting. Ibig sabihin, it will facilitate long period of time to relax the bronchial smooth muscle and stimulate the cyclic adenosine monophosphate. In this situation po, marami siyang indication. So the most of the indications are related sa respiratory, most asthma, at pag kayo ay na-expose into problems with the difficulty of breathing that is caused by the contraction or constriction of the bronchi. So that's the problem. For the contraindication, usually we need to consider yung problem with the heart. Now, with the bronchodilators po, you must take into consideration that do not administer long-acting drugs more often than described. Example ha, long-acting. Ano yung mga long-acting natin? Yung sinabi natin, di ba yung Combivent, yung ipratropium plus albuterol Combivent, tapos yung isa yung ipratropium plus bromide atrovent. For example ha, ang prescription of the doctor, nebulization prescription of the doctor is every 4 hours or every 4 hours, yeah. Nag-first nebulization siya. Then after the first nebulization niya, hindi ka na satisfied because hindi ka na totally na relieve. So after 30 minutes, nag-nebulize, hindi pa rin na-relieve. So nag ano ka na naman, what do you call this? Nag-nebulize ka na naman. What is the problem is it may cause induced tachycardia. Mag-i-increase ang heart rate mo kasi what's the response? Adrenergic eh. So meron niyang effect si heart. So pwedeng mag-adverse reaction siya sa tachycardia at pwedeng magkaroon ng problem yon. So let it be na class careful na even salbutamol, albuterol, nebulization, make sure that it could be given on an interval prescribed by the doctor. Kasi pwedeng mag-complicate yan into tachycardia and possibly may occur death. Kasi too much workload of the heart. So pwedeng na yan, pwedeng mag-lead yan ng problem with increased oxygen demand at pwedeng ikamatay ng pasyente. So careful ha kasi pwedeng mag-lead yan sa ganon. So another is other than the purpose of the adenosine cyclic adenosine monophosphate is to instruct the client to have fluid intake of 2 to 3 liters per day. Except if the client has congestive heart failure, merong enlargement of the heart, may pitting edema, hindi masusunod, it will not follow the 2 to 3 liters per day. Why? It's because it may induce further retention of fluid. So moreover, usually pag may mga nagbo-bronchodilator at the same time may congestive heart failure, limited lang siya until 1 liter per day, compared to a normal individual who may have 2 to 3 liters per day. So you must take that into consideration. So next, probably I may have first a break before I continue with metal santines. So we may have probably a 10-minute break. Okay, a 10-minute break for you to hydrate yourself, stretch your extremities, and eventually manage to fulfill your Maslow's hierarchy of physiologic needs. So thank you very much. We will be back after 10 minutes. Okay, class? So we will have the resumption of our discussion. Are you still with me na? Class? Hello, class?
Yes po.
Yes po.
Okay,
Nandito pa
salamat.
po.
Kinakabahan ako. Kala ko I'm alone na lang. Okay, anyway. So thank you. So let us now continue. The next bronchodilator that we are talking about is methylxanthines. Okay. Methylxanthines, sometimes xanthines. Okay, methylxanthines. Um its purpose is still the cyclic adenosine monophosphate. So it will inhibit the breakdown, which is common with what the first drug, the adrenergic agonist drug. Okay, adrenergic agonist drug is common. The cyclic adenosine monophosphate. Most of the methylxanthines are drugs ending in pilin. So aminopilin, theopilin, dipilin. So any drug ending in pilin are methylxanthines. So these are bronchodilators. Okay? And most common when it comes to this aspect is still with the bronchospasm. So anything. So yes, sa COPD, yung those who may have asthma, yung may mga problem with the bronchitis. So neonatal apnea. So ano yung neonatal apnea? Yung neonatal apnea is if there are cessation of breathing of newborns. So the best drug that may be given are methylxanthines. Most common drug that are given for neonatal apnea if there is cessation of breathing. However, this is contraindicated with status asthmaticus. What is status asthmaticus? Status asthmaticus is a higher level complication of asthma. Usually, if asthma are being treated conventionally, and the person with asthma did not respond to the conventional treatment, and worse, continuous bronchial constriction happened, that is status asthmaticus. So methylxanthines may not be anymore uh, uh, prescribed to clients with status asthmaticus, because however, for those clients may have status asthmaticus, usually they will be intubated already and other drugs may be prescribed. Now, in methylxanthines, um, we need to monitor the serum drug level. So ano yung mga serum drug level? So ang therapeutic level po ng methylxanthines is 10 to 20 microgram per ml. So meaning pag nag 20.1, 20.5, 21, 22, 23, toxic level na yon. So withhold the drug, discontinue, not withhold, it's already discontinued the drug if it reach already the toxic level. Now, if the client is taking methylxanthines, then better to instruct the patient to reduce xanthine-containing foods. Ayan. Ano ang mga xanthine-containing foods? These are yung mga cola, coffee, chocolate. So these are mga xanthine-containing foods. Pag nagtitake sila ng mga pilins, as much as possible, you need to reduce these xanthines containing food. So very important ito because it may cause the possibility na pag ang patient who is taking methylxanthines, mag-reach siya, makadagdag siya doon sa level sa blood at mag-lead sa toxic level. So as much as possible, i-reduce po ang mga xanthine containing foods. So we have the adrenergic agonist drugs under the bronchodilators. We have also the methylxanthines ending in pilins. Now we'll proceed with corticosteroids. Familiar from the start up to the end, from the pregnancy up to the respiratory, corticosteroids are given. Class, if the client, just like with COVID-19, alam natin na they are the ones that really encounter a what you call respiratory distress. In that respiratory distress, kasi usually sabi ko nga sa inyo, in terms of inflammation, of airway inflammatory response, nagre-release kasi ang body natin ng mga biochemical mediators. Ito yung sabi ko nga sa inyo, cytokines, kinins, serotonin, histamine. These are the common biochemical mediators, pero somehow kailangan ito ma-prevent. Kaya that's why for asthma, the patient is given antihistamine kasi ito yung biochemical mediator na nagko-cause ng inflammatory process sa airway passages. So other than kinins and serotonin, so ang purpose ng corticosteroids is to block, to release ito, counteract biochemical mediators kasi pwedeng mag-cause palalo, it may lead further narrowing of the airway. So as what we have mentioned, these are the drugs ending in zone. And additional to it is we have side o yung IDE. So hydrocortisone, dexamethasone, fluticasone, prednisone. Ito na, budesonide, flunisolide. Usually, ang mga budesonide at flunisolide, these are mga metered dose inhaler, yung mga PAP, okay, mga PAP given as metered dose inhaler. So most common drug that are given sa mga ito sa COVID yan ha, pag may mga inflammatory conditions na at bumababa ang oxygen saturations, they are given with hydrocortisone and dexamethasone. These are the common corticosteroids that are given for COVID-19. Because sabi nga natin, yung cytokines ay isa sa supposedly nagpe-prevent ng inflammatory condition, pero pag nag-cytokine storm na kasi siya, lalo siyang nagka-counteract na yung supposedly action niya to prevent inflammation. Nagli-lead na siya into inflammatory process. So most common pag COVID-19 is hydrocortisone and dexamethasone. And budesonide and flunisolide are most on the metered dose inhaler or PAPs. So we have usually mga chronic bronchitis, inflammation, asthma, common, treat allergic rhinitis. So very common sa may mga rhinitis dyan. So when you wake up in the morning and you sneeze at all times, ito yan yung may mga rhinitis. So that's why they are given yung mga IDE, yung mga pang-puff, inhalants din as well. Yan pwede may mga corticosteroids na inhalants and puffs, metered dose inhalers. So the common corticosteroids usually kasi you will instruct the patient to rinse mouth after using inhaled corticosteroids, inhaled steroids. Why? Because usually ang mga inhaled steroids ay nakaka-dry ng mga mucosa. And chances kasi this may lead to sores, mga mouth sores or singaw. So need to rinse. Okay? Para ma-maintain yung integrity of the oral mucosal tissues. Not other than that, give oral dose of the corticosteroids with food, because as what I have told you, that the steroids may have the possibility of irritating the gastric mucosa, and sooner if this may lead to an inflammatory condition, pwedeng mag-peptic ulcer disease ang patient natin. So it must be given on a full stomach. So next, we now proceed to leukotriene receptor modifiers. Konti na lang po. So leukotriene receptor modifiers are also given, binibigay din ito. These are given to COVID-19 kasi kung talagang, and usually for mga severe asthma attack, these leukotrienes are also a receptor. Kasama yan ng mga ng biochemical mediators na kines, serotonin, histamine, leukotriene. Pag nagsama, this will have a full force action. Talagang constriction of the bronchi and airway passages is the problem. Usually, this is associated with inflammatory condition of asthma. Kaya pag ang person, if we will associated with COVID-19, has continuous dropping of oxygen saturation, other than the hydrocortisone and the dexamethasone, leukotriene receptor modifiers are also given. Kasi ito na yung these are already the high level and severe level of inflammation of the airway passages. So just the same as for the asthma attack. Kung may mga signs na ng status asthmaticus, leukotriene modifiers na ang ibibigay. However, these are the drugs ending in cast. So Montelukast tsaka Zafir Lucas. Okay, so mga cast, yan, mga cast ang huli. Sa steroids, sabi natin, we have zone, and ide. Pag mga Montelukast, Zafir Lucas, cast, these are leukotriene receptor modifiers. So this is also for anti-inflammatory. So in this situation, usually ano to prophylactic. If we say prophylactic, preventive. Okay, prevention for asthma attack sa adults and children. And Montelukast is used in children as young as 12 months. So these are the drugs that are choice for children. Again, this may not be anymore a treatment of choice if you will notice pag status asthmaticus na. Kasi the status asthmaticus is really the highest level of effect na on the bronchial smooth muscles na. Hindi na maititreat ng bronchodilators, ng adrenergic agonist, ng methylxanthines, ng leukotriene receptors, modifiers, hindi na. So that's why it's contraindicated for status asthmaticus. Usually, pag mga status asthmaticus na yan, they will be subject for intubation na. So, on the other hand, best absorption for this leukotriene receptor modifiers na it can be given 1 hour or 2 hours, 1 hour before. Okay, 1 hour before or 2 hours after meal for best absorption. So you may have a choice. It could be 1 hour before, pero if it is after meal, it must be 2 hours after meal. So it is best absorbed when given at night. So that's why if you will encounter itong mga cast, mga Zafir Lucas, Montelukast at night po ang binibigay simply to facilitate best absorption din as well. So let us now proceed to anti-tussives. Okay, ano naman ang mga anti-tussives? Para ma-differentiate natin, kasi sometimes merong expectorant, may mucolytic, may anti-tussives. So para so that you will be more familiar. If we say anti-tussives, the action of anti-tussives are to suppress coughing. These are yung walang phlegm, walang secretions, pero you want to control, very irritating yung sa throat. So yung anti-tussives, sinusuppress niya yung coughing. Okay? Yon ang anti-tussives. Expectorant, from the term self-expectorant, hindi yung nag-expect sa lab life Yung expectorant is if there are obstruction of the airway, yon kailangan ma-release. Pero ang anti-tussive, there's no specific part of obstruction, but there could be irritation that causes the narrowing of the airway passages. So sinusuppress niya lang yung coughing reflex. And most of the drug that are anti-tussives are dextrometorphan and diphenhydramine. So diphenhydramine, antihistamine din yan. Pero ang torpan, yung lahat ng metorphan, these are basta non-productive cough, dextrometorphan. This is the choice dextrometorphan, non-productive because it's usually, for example, it disrupt your sleeping at night because of that irritation on the throat and it causes the coughing. So anti-tussive is the one, sinosuppress niya yung coughing reflex. So non-productive. So next is usually contraindicated ito. So hindi pwede siya. Contraindicated with hypertensive, pregnant, and breastfeeding kasi nga since sinusuppress niya yung reflex, this may cause the possibility that it may affect or masuppress din yung function of the heart, and it may cause suppression also. You want to answer? It may cause also suppression for a while. Okay, let's continue. It may cause also a concern with the pregnant and breastfeeding, because we all know that it may pass through the plasma, and possibly the mode of minor excretion of the drug will be through the breast milk, which basically may be transferred through the breast milk and excreted by the breast milk, which is a minor excretory mode or mode. Pero yun nga, for those who are breastfeeding, it's not, because it may suppress. Kasi pag sinabi natin suppress, direct na kasi sa brain yung yung sa medulla mismo, it's pwedeng maka-affect din sa nervous system ng both mothers and the child. So, next drug. We are already done with antitussives. So, it just repeated the slide. So, let us now proceed with next, expectorants. Ayan. Yung expectorants naman, you are experiencing cough which you feel has mucus secretion, but you cannot able to spit it out or to put out. So that's why expectorant. Okay, kailangan mong ilabas. So usually the expectorant is, the purpose dito, it's the usual reason why it can't be removed out of the airway. It's because of too much viscosity of tenacious secretions. So too much secretion itself. Too much secretion itself is the one. So that's why this may induce, okay, this may promote the removal of the secretions in the airway passages. So expectorant. So you are experiencing cough, but it's in the airway passages. You can remove it by coughing. You need expectorant. If it is non-productive cough, non-productive, no secretions, just an irritation of the throat, you want to suppress the coughing reflex, it's the antitussive. So most of the drug which are expectorants are guaifenesin. So dextromethorphan, sa cough lang siya, antitussive. Pero ang guaifenesin ay usually ito yung may secretions but you cannot cough it out, kaya kailangan na expectorant. So usually it's a it is associated with cold and upper respiratory tract infections. Sa mga sinusitis, influenza, bronchitis, these are the common drugs given. So a question, Din, bakit po sabi kapag may phlegm, ideally daw po dapat ilunok? Ideally, dapat daw po ilunok para sa stomach mapunta at sa hydrochloric acid. Okay, ganito. Parang I haven't tried I haven't tried to have such health education to the client that if it's on the throat and it cannot be expectorated, then probably you swallow it and may the hydrochloric acid is the one that may synthesize. So actually usually pag phlegm is to liquefy. Ang non-pharmacologic action natin is to drink fluid. So yung pag fluid kasi nag-aano yan nagdi-dilute ng secretions, nagli-liquefy ng secretions until the coughing reflex enable to cough it out. Pero pagka kasi ang problem natin, we will consider yung swallowing of the phlegm. Pwede kasi siyang hindi magtuloy towards the kunyari hindi magtuloy hanggang sa stomach, tapos mag-ano siya sa mag-attach siya sa esophageal tissues. Pwedeng mag-lead into infection of the upper GI. So yun yung isa. Paano kung hindi siya magtuloy papunta sa stomach to be synthesized by the hydrochloric acid? So that's the risk. That's eventually the risk. Lalo na kung for example, if the phlegm will be swallowed tapos magkaroon ng premature opening yung sphincter that controls the opening towards the respiratory tract, pwedeng mag-lead yan into the aspiration at pwedeng mag-lead din sa pneumonia. So yun yung mga possible considerations. So as much as possible, liquefy through the fluid intake. And if it's not possible, you're still coughing pero still it's full of secretion on the throat, better you may have the guaifenesin. But these drugs are prescribed. usually prescribed. Lalo na yung mga anti-tussive, yung mga dextromethorphan, guaifenesin, these are prescribed because these are the drugs that are being abused. So ito yung mga hindi pwede talaga na over the counter. So hoping I answered your question. Next po, usually caution, let us have a caution sa patient not to take guaifenesin for persistent cough. Ibig sabihin, for example, may phlegm, you can expectorate, tapos inom pa more ng expectorants. Kung persistent yung coughing and it can't be removed by the guaifenesin, much better not to continue and seek the professional medical advice. So question, Dean, bakit po hindi pala, it's already answered. Thank you. So next, other than the expectorants, mucolytics. I think this is the last. For mucolytics, from the term itself, muco. Okay, muco. The difference nung isa is it liquefy the tenacious viscosity of tenacious secretion so that it could be coughed out. Ito naman ang mucolytics, directly pine-prevent na, it prevents the mucus viscosity or too much viscosity or lapot nung phlegm. So kaya nga siya from mucus secretion lytic inhibit. Now, into the perspective that most of the drugs these are usually given din sa COVID. Acetylcysteine. Ito yung usually pagka is in the inflammatory conditions kasi yung mga goblet cells and glands, mucous glands, the mucous glands, if the mucous glands are inflamed, it will continuously produce mucus secretions eh. So yun din yung isang effect ng inflammatory response ng COVID. Kaya usually they prescribe acetylcysteine at ang acetylcysteine po ay mixed with it mixed with the water, with the 200 ml of water at iniinom yan so that yung upper respiratory tract ay basically nagpe-prevent, it clears the airway passages. Actually ang acetylcysteine is an antidote for acetaminophen is acetaminophen and paracetamol toxicity. Acetylcysteine is the antidote for it. So pag nagparacetamol toxicity and acetaminophen toxicity, acetylcysteine is an antidote for it. Okay, so always take into consideration na we prepare this beta adrenergic agonist by aerosol. So what do you mean by aerosol? So it could be by nebulization, inhalation, much better because this could be effective. So I think that ends up my drugs affecting the respiratory system. Okay, so please turn on your cameras if you have questions. If you have questions on drugs on the respiratory, actually the coverage of the finals are cardiovascular drugs and the respiratory drugs. We have already finished the topic for the final period. So since we are scheduled for the final exam 1 of the cardiovascular drugs affecting cardiovascular system, do you want to continue na the exam or you may have 15 minutes to have the lead time? The examination is scheduled pa naman by 7:30. Any response from the group?
No, no po, sir.
We can start na or by 7:30?
No, no po.
No na. So any objection from the group? Any objection from the group? Okay, it seems none. So may I request everyone to open their cameras. So we have the 10-item multiple choice and drugs affecting the cardiovascular system. So ang coverage po natin for the final exam is more coverage natin is etong cardiovascular and respiratory nasa 60%, 20% comes from the midterm and 20% comes from prelim. So that's the coverage. It's cover to. So if you can still have access on the examinations of the prelim, the midterms, you can have those review, and your examination will be this coming Friday. Your final exam will be this Friday. This coming Wednesday will be the final quiz 2 and long exam. So yung coverage ng long exam ay yung cardio and respiratory drugs for the long exam, at yung final quiz 2 yung respiratory drug. So by Friday, final exam. Okay? So I'll just accommodate questions. Yan. So Friday. Do you want it Wednesday already, the final exam? No reaction. Naghang lahat. Naghang. I think if it could be Friday, I'm the last professor ba that will end up the cycle. Okay. Sige, as much as I wanted to reschedule it by next week, but it's already the end of the cycle. Pero I will be with you. I will be with you. Probably if I still have the time tonight and by Wednesday, I may record rationalization of your prelim and midterm. I will rationalize your examination and I will have it recorded if you wanted to, so that para at least you can just watch it and probably you can have an audio of it. So most naman of the questions will come from these examinations pa rin and this final period. So if the time permits, I will try to record the rationalization of the exam of the prelim and the midterm. So okay, so I will change the time of the exam for a while. So but for the meantime, I'll stop